Hi guys, welcome. I hope all of you are looking into the videos of the PSM resident class. If you're not, I guess you're missing out on this. And this particular video is on a very interesting topic which you must be knowing. And if you don't, just watch this video and enjoy the video. If you have any queries, any doubts, or any particular topic you want me to teach, you can just drop me a message on my WhatsApp number. The details are given below. Yes, guys?
Hi guys, good evening all of you. Welcome to this discussion where we are looking into hands-on practical learning on qualitative research. Now in the DAMS PSM resident module, currently we are reading about qualitative research, and I have one of my wonderful student and colleague who herself has done a qualitative research. So I've invited her to share her experiences of qualitative research with all of us, which will make us understand that, boss, why quali is the in thing if you are looking as a experience level. So with me, I have Dr. Kirti. She is a second year postgraduate in community medicine at Ahmedabad at NHL Municipal Medical College. She will take us through her journey of this mixed method study about how she did it. Over to you, Dr. Kirti.
Good evening, everyone. Myself is Dr. Kirti Mittal, second year resident from Srimati NHL Municipal Medical College, Ahmedabad. I have done a mixed method study on the topic diabetes detection uncovered. It was basically identifying strength and weaknesses in active case detection within urban primary health systems. So we are continuing with the background and rationale. The rationale of my study was to diabetes detection cases for active case detection, and which is the first step towards diabetes related morbidity and mortality. My aim was to evaluate strength and weakness of active case detection strategies, which is used in identifying undiagnosed at community level in urban settings under NEET. So going straight to the methodology, it was a mixed method study. The study area was Urban Primary Health Center Pardi, which was selected using convenient sampling as it was close to my institution. The study population was selected as ANM, nurse midwife in UHC Pardi, and beneficiaries above the age of 30 years from NEET program. So there were three parts of the study. Two sessions of qualitative study. One was focus group discussion with ANM. Second was beneficiary in-depth interview, and third was quantitative study where secondary data was taken from UHC from the NCD portal. Coming to the sampling, UPHC party is divided into 7 pockets. Convenient sampling was done to select a single pocket, which was called as party 5. Convenient sampling was done to select 21 beneficiaries. These participants were interviewed and they were stratified into slum, non-slum and migrant areas. Only diabetic patients from NCD register that was maintained by the ANM were selected. So in total, 21 participants were given an in-depth interview. So focus group discussion, a single session of focus group discussion was held with the ANMs posted at UHC. Generally in focus group discussion, the sample size is 10 to 12. Here we have taken 10 ANMs that were all the 10 ANMs that were posted at the UHC. It was conducted by senior faculty, my department. She was the moderator, and it was done in round table arrangement at the UHC, ensuring favorable environment. The focus group discussion lasted for 40 minutes and it was audio recorded after informing the participants. The session timings and the site were discussed priorly with the medical officer and the ANMs. So this is the photo of the focus group discussion, where on the right you can see the moderator and the left side all the ANMs. We discussed about various points. This focus group discussion is a kind of spontaneous flow discussion where there is no rigid structure, but there were some points that that were planned to discuss. These included training of the ANM, the activities that are carried out at the NCD screening by them, focusing on diabetes and the problems, issues these ANM are facing, their impact of the screening on the community, and then the suggestions from the A&M were also taken how we can improve these NCT screening further. Second part was beneficiary interviews. These beneficiaries were selected at the NCT screening camp, which is conducted as a part of NCT screening in the outreach areas. These were selected during convenient sampling. 21 participants agreed for the in-depth interview. They consented, and then their interviews were taken. And it was ensured that no third-party presence was there. Each interview lasted for 20 to 30 minutes, and it was a one-to-one session. The questionnaire was open-ended. For basic demographic details were taken like age, sex, family history of diabetes, duration of diabetes, whether they are taking any treatment or not. And after this second part, they were asked about what facilities or what services they are receiving at the NCT screening camp. And there was no, options were given. It was not like quantitative study. So basically, whatever patient said, like temperature was measured, BP was measured, and RBS was measured using glucometer. Their history was taken. They were asked about the complications also. They were asked about the medication history by the medical officer. With their weight was measured, waist circumference was also measured, and they were given treatment also. It was in conjugation with the camp that was conducted that is conducted quarterly. So screening and the camp was conducted, that the quarterly camp was conducted. It was conducted in conjugation with that. So medical officer was also there along with the screening, and the treatment was also given to the patients. And then third part of the interview, they were asked about the problems or issues they are facing, like accessibility, seating arrangement, or other basic facilities at the camp, like drinking water, etc. And then in the fourth part of the interview, they were asked about what suggestions for improvement, what other services they would like to receive at the NCT screening camp. And lastly, they were asked about whether they would attend the screening camp, another screening similar camp or not. And if not, what are the reasons that have prevented them from attending the other NCT screening camp? So these were the two parts of the qualitative study, and third part was quantitative, where data from the NCT portal was obtained from the UHC. So in FGD, the points I have discussed earlier, each A&M have given their own answers. Some told that they have received training. Some told that they did not receive training. Some of them said that they have received training, but it was inadequate. It was a theoretical teaching. No practical teaching was there to how to measure the blood pressure and how to measure the random blood sugar, how to measure the waist circumference properly. So there was coding was done, and different themes were created based on these answers. The themes they were created was human resource, their strength and weaknesses were identified. Human resource, like if A&M are not deployed in particular areas, how they are managing that areas. And then 30-year eligible population enumeration was done by ASHA. Feedback form was filled or not. This was given as an answer like the part of the diabetes, the NCT screening activities that they are doing. Then awareness of the outreach camp, mobilization activities were also asked. And micro planning, screening done, referral done, specialist camps that were conducted, and satisfaction among the beneficiaries were also observed. Then tracking, that is the unique IDs or NCT cards were given, and the record keeping. So these were the parameters that were identified based on the answers that the beneficiaries and the A&M have discussed during the qualitative research. Limitations of my study involved the generalization. Obviously, this cannot be generalized to all the UHCs. And the information is collected. It is based on subjective perception of both A&M and the beneficiary interview. So this is subjective. Yeah.
Okay. Thank you, Dr. Kirti, for a quick presentation. Let me tell my audience over here that our objective of discussing this topic is not to look into this topic and the findings. We are actually trying to understand about quality research and few pointers which will come out from this. First question, Dr. Kirti. Why did you do
Yes.
a mixed method study and not just a quantitative or just a qualitative study?
Also because uh, when we were doing focus group discussion and beneficiary interviews, there were some shortcomings that we encountered, and there were some claims that were made by A&M, like we are maintaining the registers, like we are keeping track of the patients, we are doing follow-up. So to support that evidence, I have also done the quantitative study where I've cross-checked how the number of screened persons, how they are maintaining the record, how the CBAC forms were filled. So in quantitative study where it was mentioned like total 4,023 CBAC forms were filled as they claimed, but there was no physical record available. So whatever was discussed during focus group discussion and from the in-depth interview from the beneficiaries, this has to be supported from the quantitative study.
Excellent.
Okay. And like they were, okay.
Yeah, Kirti, please continue.
Like they told me only the diabetic cases that have taken treatment from the UHC were given unique ID. Those patients who were diagnosed at the UHC and they did not start treatment from the UHC. They might not have taken any treatment. They might have started their treatment from a private practitioner or some other health facility, maybe from other government hospitals. They were not given unique ID. So the number of diagnosed cases maintained at the UHC were lesser as compared to the original cases in the community.
Okay, great.
And people who attended the screening camp and the same person, if he or she has attended the screening at the UHC, both screening episodes were given separate numbers. Single patient visited twice for screening at two different intervals. They were counted as two different screening episodes. So the number of screened population actually they were showing more as compared to the original.
Okay.
Like here it is showing diagnosed diabetics 716 and cases on treatment. They cannot be exactly same because some diabetics they won't take treatment from UHC also.
Okay, beautifully
And this screened number is overestimation.
Okay, excellent. So guys, I hope you
Yes.
understand the mixed method study actually enhances the research quality. It cross-checks whatever has been claimed in quali. If you do only quantity, you will have only numbers. So you will never get a perspective. So mixed method study gives you that advantage. Yeah, probably Dr. Kirti will also agree with that. Now,
Yes, sir.
second question, Dr. Kirti. Now, when you talked about FGD, did you actually make a FGD guide?
Yes, sir. We made FGD guide. There were no good questions. Like we were sure we will start from training because training is the first step of PNM. We will start from then we will diabetes related activities you do in the community, and then how you approach the out like a boundary of it. Okay. And then areas where ANM are not posted. And then we discussed about mobilization. Then we discussed about screening, like how they do the screening, the method of the screening that they use, and then what are issues they face in screening camp and what are the impact of this screening on the community.
Okay. Now, the last question. You talked about something called as coding. You said that you coded it and you made themes. How did you actually make themes from the codes? Can you just give us a small example so that our audience understands it, how it is done?
Okay. So here, for example, we asked this question, have you received any training on diabetes related activities? Some of the ANM answered that they have received training. Some of them answered that they have received only single session which covered all the aspects of ANM, MCH, immunization, everything, family planning and this NCD training. So all the aspects were covered, not specifically NCD, and it was not a practical training. Some of them said this. So here we have done the coding. So mentoring new ANMs, some of them told that we did not receive training, but the existing ANMs supported us while for carrying the NCT screening of the activities. So this we categorized as human resource, like vacant post, mentoring, and training. That is categorized under human resource. And then we asked about the activities. So ANM told like Asha is doing all CBAC and enumeration, and they are supporting the ANM. So here enumeration, CBAC forms, 30-year above population, awareness of the outreach camp. The first activity is 30-year above population, that is CBAC form is filled. Second is mobilization. So like they told, like we visited each and every house before the camp also, on the day of camp also. So this code was mentioned under awareness of the outreach. And the same question was asked from the beneficiaries also. How did they come to know about the camp? Some of them told like ANM visited. Some of them told Asha visited our houses. Some of them told like neighbors told us. And some of them observed the camp directly on the day of the camp. Like direct observation. Like something was going on and they went to see.
Okay.
So this is how we did. Like ANM told me they have a micro plan on which day, on a day of the week, they will visit which area, how the screening will be carried out, what are they going to measure, BP, RBS, weight with BCC, that is behavior change communication. They will give a referral slip to each patient. Specialist camp will be conducted, and satisfaction among the beneficiaries was also observed. So this was mentioned in screening, referral, diagnosis, and treatment. And then they told that we also track, we also follow up the patients who were referred from the camp to the UHC, whether they have started treatment on from the UHC or not, or they have been put on any anti-diabetic treatment or not. So this was categorized under tracking. And then they told we maintain the records, both on the registered and uploading on the NCT portal also. So this was categorized under record keeping.
Okay, excellent. The last question. What challenge did you face with doing a quali?
Sir, the group of 10 ANMs that we were doing focus group discussion with, some of them were there for more than 10 to 15 years. Some of them were there for less than 6 years. So obviously who are not there for long period of time, they were quite hesitant to speak in front of those who are experienced. Even if they were facing any issues, so they were scared like if this is something that they should share or not. Like if they share their issues, so indirectly they thought that the senior ANMs may get offended, like they may feel like attacked, like it's their responsibility to keep the new ANMs updated. Like it's their responsibility to solve their issues. And if there are issues, then it comes on the senior ANM. Like, and something was patients also, since it was in-depth interview, I was writing completely. It was not just yes, no question. So they were also curious to know like, why am I asking? Because many patients told like, maybe they might have faced similar surveys earlier, because this area is close to the medical college. So maybe some other PG student might have done some similar research, kind of. So they were telling like, you always ask what do you want as an improvement, but we generally do not see any improvement there. So this was also a challenge. And then when I told them like I'm going to record this focus group discussion, so they were quite hesitant to speak. So we have to, repeatedly we have to reassure them that anonymity will be maintained. This will not be shared with anyone. Like this is for research purposes. We are not going to mention anyone's name or even their experience or age or what is their work profile with anyone during the research study, and and in the publication also, we are not going to mention their names or their personal numbers or ID or photographs or anything.
So basically,
this was the record. And NCT portal technical issues also, they were present. After 2, 3 or 4 rounds, I was able to retrieve data from NCT portal. It was just a matter of few minutes, but still 3 to 4 visits to the UHC, because NCT portal keeps on lagging and sometimes data is not updated. Like technical issues were also there.
Okay, great. So thank you, Dr. Kirti, for bringing out this excellent discussion, because we could understand some basics of quali over here, First, as you mentioned in the last point, confidentiality or anonymity is a very important aspect. Next, whenever we do an FGD, there will be a lot of unequal participation because, as you mentioned, there were some senior ANMs who were much vocal than the junior ones. Then there will be logistic issues definitely because you are doing a community-based research. So you don't expect that it will run as an efficacious model, just ideal. It will be a real life setting. Yes, but overall, if you look into the plus, as you brought out very well, definitely a mixed method study gives you a greater advantage than a simple quantity study because it validates whatever has been spoken in quali and vice versa. And probably the behavior, the way you told that, okay, that the young ANMs or the new ANMs are not ready to express, even though they're having issues, that probably comes up to the forefront when you actually do a quali. Thank you, Dr. Kirti, for your valuable time. This was actually an enriching
okay,
experience.
yes.
Yeah.
Okay, one extra point I forgot to mention. Senior ANMs told that no one has asked them till now what issues they were facing.
Okay.
And even the patients were also surprised at this question, like what services extra you would like to receive at the screening camp. Everyone asked them about the symptoms and if they are facing any issues. No one asked about their suggestions, both from ANM side and the patient side also.
Okay. Excellent. And that's probably what quali is. Actually, it gives you that human touch rather than just making it as a robotic yes, no answer. It gives you a human touch. That's what quali brings about. Yes. Thank you, Dr. Kirti, for your valuable time. We will again catch up further into further discussions. Yes. Thank you guys. Logging out both of us. Bye bye. Take care. See you guys.
Thank you guys. Thank you for watching this exciting video. Do drop in your messages, your comments, or any improvement you would like to see, or any other topic which you want me to take up in the PSM resident course. This course, which has been running for almost last 1 year with almost 500 active subscriber across the country, PSM residents of the first year, second year, third year, plus even I do have senior residents and even some consultants, faculty members doing this course. So do not miss out on this. Please, please, please subscribe. And if you have any queries, do reach out to me. Your host, your dost, PSM said.